Let's talk about alternative payment models. MSSP is just one alternative payment model. It was broken out by Medicare as a permanent project group in Medicare. Most other APMs run by the Center for Medicaid and Medicare Innovation are used to test techniques that they might add to the MSSP. So they are now different topics within within Medicare. Now, first about quality measurement, and I'll reiterate what I've said in the section about MSSP. Any MIPS APM can elect to use the APP or the APP plus measure set to generate a quality submission for their MIPS eligible providers. It's unavailable to traditional MIPS participants. Only the MSSP must use the APP plus measure set. Any other APM can use either of them or neither of them. So be aware that it is there. Now, the new complex organization adjustment they've implemented for MSSPs, which typically have multiple independent tax ID numbers, multiple EMR types. For APMs that also any APM, whether you have multiple organizations, multiple EHRs or not, would appear. You also get 1 point for every ECQM submitted with the same limitations I've described elsewhere. That 1 point can't drive you above a perfect score either for the individual measure or the composite score. Changes in promoting interoperability, the same ones that apply to MSSP. There are actually no new rules about APMs in the 2025 final rule, but one of the most consequential rule changes was finalized in the 2024 final rule that goes into effect in 2025. Starting then, all participants in APMs, regardless of QP status, must be on certified EHR technology and must make a promoting interoperability submission. There is one big, if understated, exception. Providers have a temporary or permanent exception to CHRT requirement, get the same exception for participation in an APM. They don't need to use CERT. They don't need to make a promoting interoperability submission. That is, includes small practices, non-patient facing, physician, hospital-based, or ambulatory surgical center-based providers. An interesting side note on this promoting interoperability requirement pertains to facility-based providers. Medicare offers an exception to promoting interoperability requirements for those providers who are facility-based and therefore have no control over the EHR and use at the facility. But the only automatic grants of that exception occurs for hospital-based and ambulatory surgical center-based providers. And for them, it only applies if at least 75% of their volume comes from a single facility. Providers in other facilities like skilled care and other long-term care facilities, or providers who serve multiple facilities with no one of them rising to 75% of their volume, must make an EUC application to be granted the exception. Now, and of course, that EUCA application has to be repeated each year that it still applies. And in our experience with our clients who've made these applications, it's granted quickly and almost automatically or what appears to be automatically by Medicare, but it won't happen without your application. Now, additionally, it applies to all APMs, including the MSSP. There's been an update to QP, that is qualified participant and partially qualified participant thresholds for 2025 and beyond. This has been delayed for a few years because of COVID, but they're finally progressing to the previously scheduled advancement of these thresholds. If you're in a Medicare option APM, QP threshold is at 75% of your payments come through that the MSP or the APM, or 50% of your patients. Partial QP, the threshold for payments goes up to 50%. from 35, and the threshold on patients is 35%. I expect there's likely be fewer QPs, perhaps the same number of partial QPs. And in the all payer option, the QP threshold goes to, based on payments, goes to 25% of your Medicare, 75% overall. And based on patients is 20% of your Medicare patients, 50% overall to hit QP status. Partial QP, 20% Medicare, 50% overall of your by payment, or 10% to 35% overall on patients. So again, whether it's Medicare option or all payer option, those thresholds become a QP or partial QP toggle up rather significantly for the 2025 year. Now, the APM, the advanced APM incentive payment, has been changing with a few, as previously scheduled, with a few alterations to that. From the inception in 2017 through 2024 performance years, the incentive was a 5% lump sum payment paid 2 years after the performance year in which a provider became a QP. And the last payment year of that 5% lump sum is 2024. So everyone should have already received their last 5% lump sum payment. For the 2023 performance year to be paid in 2025, there's a 3.5% lump sum payment. So expect that next year for your work last year. And for this current 2024 year to be paid in 2026, Medicare added, or the legislature added in March of this year, March of 2024, a 1.88% lump sum payment to coincide with the new method of that ongoing new method of incentivizing QP participation. That is a higher conversion factor on the physician fee schedule. Now, there's already a 2.5%, or excuse me, a 0.25% automatic increase in the conversion factor every year for the rank and file Medicare participant, participating physician, that is. That goes up to 0.75%. That is 3 times that standard upgrade, 0.75% for QPs. So expect that to start and continue indefinitely. You're qualifying for that in the 2024 year. It'll be paid in 2026. It'll apply to each of your Medicare payments for service that's delivered in 2026 and beyond.